of course, with any good physiology, there's always some equations as well. The alveolus is something that we look at from the standpoint of measuring or thinking about the amount of oxygen that reaches that final step in the respiratory tree. So there's a equation called the alveolar gas equation. And this helps us think about the amount of oxygen that makes it into the alveolus that's able to participate in gas exchange. And that's what's denoted by this capital A. It stands for alveolus. And then when you're talking about arterial oxygen content, you use a small a. So that's the nomenclature there. That's equal to the FiO2, which means the fraction of gas that is actually oxygen times, let me see if I can write this smaller. So fraction of inspired gas that is oxygen times the atmospheric pressure minus the ambient water pressure minus a term that stands for essentially the amount of waste gas that the lung has to deal with as well. So R stands for respiratory quotient, which is not important, but is a metabolic term that sort of is involved in the relationship with how we generate CO2. So the importance of this equation is that the amount of oxygen, and this might seem pretty intuitive, but the amount of oxygen that gets to the alveolus relates in large part to the concentration of oxygen in the gas that's being inhaled. So most of us probably know that the air that we're breathing right now is 70% nitrogen and change and only 21% oxygen. So the main thing that we do in a lot of cases in order to raise the amount of oxygen at the alveolus to therefore raise the amount of oxygen that is able to be transferred into the bloodstream is increase the concentration of oxygen that is provided to the respiratory tree. You'll also see that obviously an increasing amount of CO2 is going to be subtracted from that term. So the more CO2 that you have from under ventilation, the harder it is to oxygenate as well. So that was about 2 years of med school in 10 minutes. When talking about COVID in particular, so this is a virus that infects cells in the respiratory tree primarily. When it infects, virus goes into cell, it hijacks the replication machinery of the cell to produce more copies of itself. And in doing so, irreversibly damages the cell, ruptures the content, and spreads more viruses. So this has the effect of direct injury to lung tissue, which is bad. But when your immune system tries to respond and fight to that, there is a secondary inflammatory response as well, which in many cases can do more harm than the initial infection. So all of this leads to something that we clinically refer to as ARDS, which stands for acute respiratory distress syndrome. So where in a normal x-ray, and the other disclaimer should be I'm not an artist either. So in a normal x-ray, you have these lungs and air is loosened on x-ray. So you have basically white lungs. In people who have ARDS caused by COVID or other conditions, you see these just ground glass white appearances on the lungs, which is reflective of inflammation leading to edema or fluid and opacification and hardening of essentially that respiratory tissue, with the net effect that you have less good lung tissue that needs to work harder to provide the same degree of oxygenation and ventilation. And if you look at a sort of, if you were to look on a microscopic level, you have the alveolus here and you have this space around it where the blood vessel then comes to pick up the oxygen. This space is full of debris, it's full of dead cells, it's full of crap that makes it that much harder for the oxygen to then diffuse into the bloodstream. So the clinical manifestations of this picture happening at the cellular level are the symptoms that we're all familiar with. Things like the shortness of breath and sensation of difficulty breathing, because you are not removing enough of that CO2, which stimulates your brain to work harder to breathe, all the while you're using energy trying to increase respiration with worse tissue. Ultimately, if you get to a point where you're not able to have enough oxygen to supply your body, you're then what we call in clinical terms in respiratory failure. And if you want to sound really fancy in an ICU, you say hypoxemic, which means low oxygen in the blood, hypercarbic, which means you can't get rid of your CO2 waste production, respiratory failure. And this is what kills a lot of people who are unable to have access to some type of increased oxygenation or improved ventilation. So there's a couple of things we can do for patients prior to just putting them straight on a ventilator. So if you remember that equation, you know that that inspired fraction of oxygen is an important term in that equation representing alveolar oxygen levels. So one thing you can try and do is increase that degree of oxygen. So that's why you can see people put on nasal cannula. So little tiny oxygen prongs go into the nose, and you can generate FiO2s roughly in like the 30 to 50% range. And one of the reasons why you can't get much higher than that is because you still have an open mouth that is able to have ambient entraining of air, and you're blowing out carbon dioxide the entire time too. One step up from that are face masks. So oxygen face masks that you'll see people have. Just a simple face mask does not permit people from not rebreathing the CO2 that they breathe out. So there's a special type of face mask called a non-rebreather. So it's a mask with a little bag on it that has a one-way valve, so that when you breathe stuff out, you're not able to breathe that in. And so the only thing coming in is oxygen. And we usually talk about that from a liter per minute standpoint. And the higher liter per minute you run, the more you can increase that FiO2. And you can generally get an FiO2 up to almost 80% with a non-rebreather. And then you can, in certain situations, use a really special type of a nasal cannula called a high flow nasal cannula. So while you typically limit yourself to flows of, on a non-rebreather, you typically limit it to like 10 liters a minute or so. On a high flow nasal cannula, you can get up to 60 to 70 liters a minute of oxygen being entrained, and it has the ability to humidify that oxygen, which is a problem at higher flows of oxygen. It's very dry and can dry out the respiratory tree. So you humidify this and blow it in the nose at 60 to 70 liters a minute. And that's actually pretty effective for a lot of patients, and can actually prolong the period of time or even prevent them from needing to be intubated and permanently ventilated at all. So that's something that's a nice modality that we use a lot. It also is able to generate a little bit of something that I will come to in a little bit later, which is called PEEP. We'll talk about that as a component of the ventilator physics. So you can then also put somebody on what we call CPAP or BiPAP. And this is really an example of what we call non-invasive positive pressure ventilation. And the idea behind these, some of you may be familiar with them from the setting of conditions like sleep apnea, is that if you put a mask on and apply a positive pressure, something like 5 centimeters of water worth of positive pressure through the airways, it will kind of have this effect of stenting open those small airways and alveolus. One of the things I didn't really mention earlier in the physiology discussion is that there is an inherent surface tension on these little alveolus that predisposes them towards wanting to close up. And when they close up, they obviously can't participate in gas exchange. We have mechanisms, including a lubricant that our body secretes called surfactant to lower that surface tension. But we can also kind of stent these small airways open with things like CPAP that leaves some degree of pressure remaining in them at the end of expiration to keep them open. So CPAP and BiPAP. CPAP stands for continuous positive airway pressure, and BiPAP stands for biphasic positive airway pressure. What they basically are fancy masks that are connected to some type of generator pump that is able to apply a continuous positive pressure to the airways. Now, because it enters in through the mouth and is not directly at the level of the trachea, it's not as effective as if we had a breathing tube in that was allowing us to apply those pressures directly at the level of the lower airways. But that is also a temporizing method in a lot of these patients coming in with respiratory distress to help improve their oxygenation. It does not do much for ventilation because it doesn't affect our ability to get rid of CO2 as easily. So once people are kind of not really tolerating any of those methods, we are able to kind of keep track of this clinically by drawing what we call blood gases. So when we have patients that are coming in with respiratory distress, we're able to draw samples of their blood and take a look at the amount of oxygen and amount of CO2 that is in their blood, which gives us a sense of how they're doing from an overall respiration standpoint. And so what we'll do is we'll put them on these different non-invasive modalities and see if that can help stabilize them or turn the corner. And if we see worsening trends in our blood gases, then we know that we have to do something a little bit more invasive. So that's when we get to intubating. So we will put a breathing tube, which is anywhere from like 7 to 8 centimeters in circumference, so pretty small conduit. We'll put that through the vocal cords into the trachea and then attach that to circuits. And so what we're essentially doing is isolating the entire respiratory tree and allowing us to work on the physics a little bit more with ventilators. So there are many different types of ventilators. And this is one of the things that I kind of talked to Bo about. Today's modern ventilator is essentially an incredibly fancy computer attached to a gas delivery mechanism. And there are a lot of sensors and components that enable a very direct control of a lot of the parameters we're going to talk about. These are what I call the Cadillacs in the ICUs. And they run probably conservatively $30,000 to $50,000 a piece. There is also a very simple ventilator that is essentially what we call an ambu bag, which is an inflating bag with an oxygen reservoir that can be hooked up directly to a breathing tube, and you can squeeze it until the cows come home. There's a huge spectrum in between. This one, we can control essentially every parameter of ventilation. This one, we can control very little. We'll talk about kind of why that's relevant in a little bit. So when we have a ventilator, there are a couple of parameters that we use. We'll talk about the parameters and we'll talk about the construction of the overall machine. So most ventilators in the operating room or in the ICU, you can control and set a tidal volume. You can control and set a respiratory rate. You can control a delivered pressure. You can control the positive end expiratory pressure, or PEEP, or the amount of residual pressure that's left after a breathing cycle to help keep those small airways open. You can control the oxygen that's delivered, and a couple of other less important things. So from the standpoint of if we want to improve a patient's oxygenation, the two things that we can do with a ventilator are increase the amount of oxygen they get up into and including 100% oxygen. And we can increase the PEEP, which keeps those small airways open and prevents what we call shunt, or blood that goes through the vessels that can't participate in gas exchange. Both of these measures will increase the levels of oxygen in the blood. Improving the delivery, the removal of CO2, so ventilation, we can increase tidal volumes and increase the respiratory rate. So the more gas that you just move in and out of the system, the more CO2 you're able to pick up and remove. These goals can often be synergistic, but in certain conditions and with certain ventilator modes, they can be antagonistic as well. So you have different modes of achieving those desired goals. And this is something where I think the complexity of the ventilator and how it works can be illustrated. So you have pressure control modes. You have volume control modes. You have dual control modes. And you have assist modes. So kind of working backward, assist modes highlight an important concept here, which is that if I intubate you and put you on a ventilator and do not paralyze you, your body will still attempt to perform negative pressure ventilation while I have you hooked up to a positive pressure ventilator. So your brainstem will trigger your diaphragm to move to try and take breaths on your own. And the entire time that happens, if we're not careful, we could have a ventilator trying to shove positive pressure breaths as well, which can be very counterintuitive. It leads to something called ventilator dysynchrony, which is not good and something we try to avoid. One of the ways we avoid that is with the use of muscle relaxers. So patients that are very sick and we don't want them fighting the vent at all, we'll paralyze them. But in other situations, we have the ability to use the ventilator and use what we call flow sensors to sense when a patient is taking a breath. When a patient takes a breath, there's a flow into the patient, there's a negative flow generated. The ventilator can sense that and say, oh, hey, the patient's taking a breath right now, and assist them by providing some positive pressure time to their breath in such a way that if they were weak taking smaller breaths, they can take larger breaths with the help of the ventilator and not have it be something where the ventilator is constantly fighting them. So that is what we use in a lot of patients who are coming towards the end of their time on a ventilator or in the operating room and about to wake up from anesthesia, because they really don't have much wrong with their lungs and it's time to get that breathing tube out. And so we just make sure that they can ventilate on their own, and we'll help them out a little bit with it. COVID patients who are in the throes of very severe ARDS, 99.9% of the time they'll be paralyzed, and a lot of times they'll be turned over onto their stomachs to try and improve ventilation. It's a concept called proning, which we don't have to get into, but very essentially we're doing everything we can to absolutely maximize the efficiency of our ventilator. And so in that sort of setting, you wouldn't use an assist mode, you would have them paralyzed and take over their ventilation entirely. So the ways we do that are some things we call pressure control or volume control or dual mode. So pressure control is kind of self-explanatory. You say you want to deliver a breath with a set pressure. With volume mode, you say you want to deliver a breath with a set volume. And in dual modes, you kind of combine the two. Why are these two considerations that we would ever use. This gets into the idea and the concept of compliance of lungs. So compliance is essentially how the lung volume changes in respect to pressure. So you may set a set pressure, and there are pressures at which beyond certain pressures you can cause damage to the lung structures. And so you might want to say deliver breaths, but make sure that you only deliver breaths that are below 30 millimeters of water at a time. And that may generate a certain volume depending on compliance. You may also say, instead, I want to make sure that this patient, no matter what, gets 400 cc's of tidal volume. And the danger with that is that the ventilator will say, okay, I will give 400 cc's of tidal volume no matter what pressure I need to generate in order to do that. And that's something that can then lead to also lung injury, what we call volutrauma or barotrauma. And the idea of care with a ventilator is that you want to minimize the amount of damage you inflict on the patient's lungs while trying to let them recover from the underlying damage inflicted by something like COVID, for example. More complex ventilators in the ICU and in the OR can do dual mode, which is something that we also call pressure regulated volume control. And so we say, hey, ventilator, it would be nice and ideal if you could deliver a 400 cc tidal volume breath, but I would like you to do your utmost to avoid doing so with pressures more than 30 or 35 or 40 or whatever it is. And again, using algorithms and using the ability to continuously assess the flow volume curves that the ventilator is delivering, it can do that to the best of its ability. And it's not perfect, but it's a more elegant way of worrying about these things than just setting arbitrary pressures or volumes. So that is sort of the idea about what I'm thinking about clinically when I'm twiddling on the knobs and adjusting ventilator settings.